afternoon, respected judges and audience. My study is comparison of central corneal thickness and intraocular pressure in pseudoexfoliation syndrome in healthy individuals. I have no financial interest. Pseudoexfoliation syndrome is an age-related microfibrillopathy involving single nucleotide polymorphism of lysyl oxidase 1 gene located on chromosome 15. It is characterized by deposition and accumulation of flakes of exfoliative material over ocular structures like corneal endothelium, pupillary margin, anterior lens capsules, zonules, ciliary body and trabecular meshwork. It was first described by Lindbergh in 1917 and is a common identifiable cause of secondary open-angle glaucoma. Richter et al. In their study stated that patients with pseudoexfoliation have reduced basal epithelial and endothelial cell densities, and CCT is significantly thinner in eyes with pseudoexfoliation. Also, CCT plays an important role in diagnosis of glaucoma, as thin corneas underestimate IOP and thick corneas overestimate it. Therefore, correction factors should be added to the measured intraocular pressure in case CCT is deviated from mean values. The aim of the study is to compare the central corneal thickness and intraocular pressure in patients with pseudoexfoliation in healthy individuals. Objectives were to document and compare CCT and IOP in patients with pseudoexfoliation and without pseudoexfoliation, and also to study correlation of CCT with PXF. This is a cross-sectional study. Inclusion criteria included patients who have given informed consent and patients in group 1 with PXF and patients with group 2 without PXF. 100 patients were taken in each group. Exclusion criteria included history of prior ocular injury, ocular surgery, corneal disorders, pre-existing glaucoma, and patients who refused to give consent. Visual acuity was recorded using Snellen's visual acuity chart. Anterior segment examination was done on slit lamp. CCT was measured using ultrasonic pachymetry by a single observer. Intraocular pressure was measured using Goldmann applanation tonometer. IOP was corrected according to the CCT readings. Gonioscopy was performed to evaluate the angle structures, and dilated fundus examination was done. PXF was confirmed after dilating the pupil fully on slit lamp. Data was entered into MS Excel sheet and mean ratio and percentages of variables were calculated. Results were analyzed by SPSS software, and p-value was calculated using Fisher's exact test with less than 0.05 as significant p-value. Results: the age distribution of the eyes. PXF was present mostly in patients more than 60 years of age, and males were predominantly having PXF. Central corneal thickness distribution in group 1 was majorly between 450 to 550 microns. In group 2 it was 500 to 600 microns. The mean central corneal thickness in group 1 was 523 plus minus 31 microns, and in group 2 it was 542 plus minus 23 microns. The difference was statistically significant with p-value less than 0.01. The mean IOP without correction in group 1 was 14.9 plus minus 3 millimeters of mercury. In group 2 it was 14.1 plus minus 2 millimeters of mercury. After correcting the IOP according to the central corneal thickness, the mean IOP in group 1 was 17.2 plus minus 2.8 millimeters of mercury, and in group 2 it was 14.3 plus minus 2.25 millimeters of mercury. The difference was statistically significant with p-value less than 0.001. The mean age of patients with PXF in this study was 66.22 plus minus 15 years, which was similar to Sultana et al. Study. Among 100 eyes with PXF, 64% were males and 36% were females. This was also similar to Sultana et al. Study. The central corneal thickness was significantly thinner in patients with pseudoexfoliation. This was similar to studies done by Oscura, Spurti et al. And Firdaus et al. In contrary, there was a study done by Ibrahim F. et al. Which stated that the mean CCT in pseudoexfoliation eyes was not significantly different than the control eyes. The mean IOP after correction, in my study there was an increase of 2.3 millimeters of mercury. The difference between the IOP, mean corrected IOP in pseudoexfoliation group and normal group was statistically significant. Similar study results were seen in Priyadarshini et al. Study. Strength of the study included large sample size, readings were taken by single examiner, and gold standard methods were used. Limitations were cross-sectional nature of the study and lack of age and gender match controls. Conclusion: patients with pseudoexfoliation have thin corneas as compared to controls without pseudoexfoliation. CCT should be measured in all patients of PXF as underestimation of IOP. To prevent underestimation of IOP, as PXF glaucoma is difficult to manage and progresses faster and responds poorly to topical medications. Therefore, CCT helps us to measure IOP accurately, thus preventing secondary glaucomatous damage to the eye in patients with pseudoexfoliation. References? Thank you.
So nice presentation. What nomogram did you follow for conversion of the CCT and IOP?
Ellers et al. Chart was used as to convert the IOP according to the central corneal thickness.
Thank you for this wonderful presentation on CCT and IOP in itself. To just add on to the comment, it was a good presentation. So now again, for the benefit of the young ophthalmologist out here, the concept is now slightly moving towards a phenomenon called corneal hysteresis also. So maybe in the future, trying to compare a CCT with corneal hysteresis with the ocular response analyzer tonometers that are coming into the market, right? So the whole understanding of glaucoma is now moving towards corneal hysteresis, and the rate of progression, which was once thought to be low CCT, leads to progression of glaucoma, and it still holds good. Whereas corneal hysteresis is another parameter that I think we'll have to do more studies on. And thank you once again for this wonderful study.